Welcome back to The Explainer. Today, we're stepping directly into the shoes of an eye care specialist, and we are going to tackle a really fascinating university-level clinical case study straight out of the Melbourne Eye Care Clinic. We're looking at a classic everyday presentation that honestly hides a massive diagnostic labyrinth. Picture this. A patient walks into your clinic, and man, one of their eyes is just blazing red. It looks painful, it looks alarming, and they're sitting there looking straight at you for answers. So what do? Let's plunge right into the role of a clinical detective, because as we're going to see today, that redness, it's essentially a blaring alarm. The real trick is figuring out exactly which building is on fire. And this immediately illustrates just how incredibly complicated a quote-unquote simple red eye can actually be. Just look at the suspect board. We have a massive lineup of potential culprits here. I mean, is it angle closure glaucoma, conjunctivitis, maybe a foreign body stuck under the lid, or just severe dry eye? Or could it be something like uveitis, keratitis, or episcleritis? I really want you to appreciate the sheer complexity of this. A clinician has to rapidly sort through this entire list of potential offenders to not only save a patient's vision, but also just get them out of pain. Taking a look at the clinical evidence for our first case, notice those distinct vascular networks branching right out across the white of the eye. You see, as a clinician, you don't just look at it and say, oh, it's red. You're looking for specific patterns of inflammation. You are trying to figure out exactly which layers of tissue are engorged and how those blood vessels are behaving. It looks pretty alarming, right? But to actually solve this mystery, we're going to need a lot more than just a quick visual inspection. Right. So how do we actually interrogate this? We need a rigorous step-by-step clinical workup to rule out our suspects. Step 1, you always measure visual acuity. Then comes the slit lamp exam. That's where we check for corneal staining, everett the lids to check for any hidden clues, and we might even use a drop of 2.5% phenylephrine to see if those engorged vessels blanch, turn white. We absolutely have to check intraocular pressure, dilate the pupil to look at the back of the eye for posterior changes, and crucially, we've got to dig into the patient's history. Are there any underlying rheumatoid causes lurking in the background? It's a complete systematic process of elimination. Okay, let's dive into this. Based on that thorough workup, we've basically cornered our main culprit for this specific case. The diagnosis is simple, or sectorial episcleritis. This is a localized inflammation of the episcleral tissue, which sits just beneath the surface conjunctiva, and it's confined to a specific sector of the eye, which, if you think about it, perfectly explains that distinct wedge-shaped patch of redness we noticed earlier. Now, here's where the human element of clinical practice really kicks in, because you have a patient sitting there, terrified by this blazing red eye. As a clinician, after you've locked in that relatively benign diagnosis of simple episcleritis, one of the most powerful tools in your entire kit is just plain language reassurance. You look at them and you tell them, it's going to be okay. This will actually resolve by itself. To help with the comfort side of things, you'd suggest simple warm compresses to help overwhelm those pain receptors and maybe prescribe ocular lubricants 4 times a day. It is all about translating a genuinely scary presentation into manageable, comforting steps for the person sitting in front of you. But hold on, because here is where we get a massive plot twist. Sometimes the supposed cure is actually the problem. If a patient is really stressed about the cosmetic look of their red eye, they might start overusing over-the-counter vasoconstrictor drops, things like nafazoline, just to get the red out. But there is a huge biological trap waiting for them. Overusing those drops literally causes the eye's alpha-agonist receptors to physically downregulate. The end result? Rebound episcleritis. The eye actually gets worse and significantly redder before it gets better once you finally force the patient to stop using the drops. Okay, let's shift gears for a second. What if your clinical workup reveals a raised bump, a nodule on that red eye? Well, suddenly we need a whole new suspect board. We are looking at a completely different differential diagnosis for this nodular presentation. Could it be an inflamed pinguecula? Well, those are typically horizontal and they don't really hide under the eyelid. We absolutely must rule out dangerous masqueraders like OSSN, that stands for ocular surface squamous neoplasia, or an even deeper, significantly more painful condition like nodular scleritis. But tracking with our current case data, the most likely offender here is nodular episcleritis. So the question becomes, how on earth do we treat this tougher variant? Because simple episcleritis might mostly go away on its own, but nodular? No way. It demands a much stronger game plan. We've got to bring out the pharmaceuticals. This is going to require a topical steroid like Predfort 1% or Maxidex used 4 times a day, right alongside regular ocular lubricants and NSAIDs to handle the localized pain. And here's the crucial part for the clinician. You have to manage the patient's expectations. You need to be upfront and tell them to expect a much longer resolution time compared to the simple variant. Now let's escalate the stakes to complex scleritis. Because while episcleritis is mostly superficial, everything changes when that inflammation dives deeper into the actual structural wall, the white, of the eye. When we are dealing with complex scleritis, we aren't just handing out eye drops anymore. We have to hit this hard and fast with heavy-hitting systemic treatments. We're talking oral steroids, specifically prednisone at 60 milligrams. But honestly, even more importantly, an urgent referral to a rheumatologist or a general practitioner is absolutely critical. Why? Because in these cases, the eye is often acting as a blaring alarm bell for a much more severe illness hiding somewhere else in the body. Scleritis has incredibly strong links to systemic autoimmune diseases, things like rheumatoid arthritis, lupus, and sarcoidosis. It's also linked to severe infectious causes like herpes zoster, syphilis, and tuberculosis. The eye's literally telling us that the entire body is under attack. And honestly, this leads us right into the most terrifying clinical scenario in our source material. The silent threat. We have spent this entire explainer talking about red, blazing, highly inflamed eyes. But the absolute worst prognosis actually comes from a sclera with no visible inflammation at all. This quiet appearance can completely mask extreme scleral thinning. It can be physically melting away the structural integrity of the eye, leading straight to dangerous perforations. It proves a really chilling clinical truth for any practitioner. A lack of redness does not always mean a lack of danger. Which brings us to a final thought for this explainer. We started out with a simple red eye, a seemingly localized annoyance that maybe just needed some warm compresses and time. But by walking through the rigorous process of clinical deduction, we quickly found ourselves staring down systemic autoimmune diseases, dangerous anatomical melting, and complex pharmacological interventions. It really forces you to ask, is the eye just a poetic window to the soul, or is it actually a critical, high-fidelity warning system for the entire body's health? I really hope this clinical journey has completely shifted how you view a simple red eye. Keep questioning, keep learning, and I'll catch you in the next explainer.